Honourable Ministers, diplomats, esteemed guests, colleagues, it's a privilege to welcome you to today's discussion, a collaborative, women-led approach to universal maternal health care, leaving no one behind. My name is Gabriella Saven. I'm the Strategy and Development Officer at One-to-One Children's Fund Africa, and I'm very honoured today to be moderating this panel discussion. We'd like to start by thanking the South African Permanent Mission to the United Nations and the South African Department of Women, Youth and Persons with Disability for helping us provide us with this platform. We gather here at a unique moment in international development. The global landscape is shifting with unprecedented disruptions in the funding environment, particularly in foreign aid assistance. As financial constraints threaten to stall progress, the urgency to invest in sustainable, locally driven solutions has never been greater. This session not only provides an opportunity to discuss these challenges we face, but also a platform to explore how governments, civil society, and multilateral organizations can collaborate to drive lasting impact. One-to-One Africa Children's Fund is a South African non-profit organization dedicated to holistic community development through a women's empowerment lens. Operating in last-mile communities in South Africa's Eastern Cape, our flagship Mentor Mother program trains, employs, and empowers local women to provide peer-led, life-saving, door-to-door healthcare and support, with a particular focus on maternal child health and HIV prevention. Our approach is based on the principle that by empowering local women as agents of change, we can build healthcare solutions that are community-driven, integrated into national systems, and scalable to achieve lasting impact. Through strategic partnerships with the Department of Health, civil society, and global development partners, we have demonstrated that such interventions are both effective and sustainable. Today's panel will explore how governments, multilateral agencies, and community organizations can collaborate to advance universal maternal health care, and how women-led models like the Mentor Mother program can drive impact at scale. It's my honor to introduce our esteemed speakers. The Honorable Sasekani Manzini, MEC for Health and Acting MEC for Social Development from Mpumalanga. Ms. Manzini is a member of the MEC responsible for health in the province of Mpumalanga in South Africa. She's had a long and varied career in public service, rooted in one overarching imperative: to build a better life for all. Having grown up in the neighborhoods of Madras Village, she became the first female provincial secretary of the African National Congress Youth League, ANCYL, following time as a member of the mayoral committee in their local municipality. As an MEC, she's also a member of the Mpumalanga Provincial Legislature and serves as the spokesperson of the African National Congress in the province of Mpumalanga. In all these capacities, she serves the people and seeks to ease suffering of the marginalized, protect the vulnerable, especially women and children. She holds a postgraduate diploma in public policy and African studies from the University of Johannesburg, a diploma in marketing from the Durban University of Technology, and several other certificates. Thank you. Dr. Will Zek, Acting Director of the Program Division at UNFPA, is an Associate Professor of Obstetrics and Gynecology, holding a postgraduate master's degree in Humanitarian Assistance and Public Health. With 24 years of experience in SRHR and public health. Clinically, Dr. Zek worked as an OBGYN in both high and low-income countries for 10 years, specializing in oncological surgery, obstetrics, and fistula repair. Following his clinical work, he served in academia, the WHO, and UNICEF as both country and regional levels across Africa, Central and Southeast Asia, the Middle East, Australia, and Eastern Europe. He has numerous clinical and field projects in various contexts and has authored 160 SRHR-related publications. An Austrian national, Dr. Zek joined UNICEF's New York headquarters in 2017 and transitioned to UNFPA's New York headquarters in 2020, where he served as chief of the Sexual Reproductive Health Branch. He recently assumed a new role as chief of the Program Liaison Branch, or acting director of programs at UNFPA's New York headquarters. And lastly, Kabelo Dandala is the executive director of One-to-One Children's Fund Africa, a former investment banker whose current work is a reflection of her personal passions, Cabello lives by the ethos, that a life of service is a life well lived, which is reflected in her work. A graduate of the University of Cape Town and the Gordon Institute of Business Science, she founded and ran a non-profit organization for 15 years prior to joining One-to-One Africa in August 2021. As such, she's a seasoned leader and executive in the social development space. The previous organization, Future of the African Daughter, has been publicly acknowledged by Michelle Obama. Her work is characterized by her passionate but practical approach to her life and work, informed by the unusual balance of her professional training in finance and economics, her heart for development, and an unwavering conviction in a better tomorrow for all. She is also a former member of the UN Civil Society Advisory Group Committee and my boss. Today's event will start off by 10 to 15 minutes of opening remarks from each of our panelists. We'll then move into a Q&A with the audience and allow the panelists to have closing remarks at the end. So without further ado, thank you to the panelists for being here today, and let me turn over to you, Honourable MEC. Achieving universal maternal health care remains a challenge, particularly in rural last-mile communities, where access to services are often limited. What policies and initiatives is the Department of Health developing in order to address these challenges? And what does government see as the role of civil society in implementing these strategies in a way that is both sustainable and embedded within existing healthcare systems? Thank you.
Thank you, our beautiful facilitator, to the leaders from government and private sector, civil society that are here, health activities and justice-loving people of the world. On behalf of the people of the motherland, South Africa, I am deeply honored to be given this opportunity to participate in this panel discussion. We have assembled here in New York to not only assess and progress we have registered since the Beijing Declaration, but also take responsibility to our future as the current generation of women leaders. This panel discussion is convened to reflect on issues around maternal health and how best to defeat the scourge of maternal death. From the onset, I should mention that no mother should give her own life to give life to another. Unfortunately, preventing maternal mortality remains a persistent global challenge. The third United Nations Sustainable Development Goal commits countries to reduce their maternal mortality rate to less than 7 per 100,000 live births in 2030. I'm encouraged to announce that South Africa is not too far from achieving this target, which the UN set for all countries, as we're now at 100 per 100,000 live births, and we are working towards to reduce the 30 per 100 to get the 170. This has not been an easy task, but we're finally turning the corner as our numbers demonstrate a consistent decrease. And of course, thanks to yourself who are assisting us in the Eastern Cape, meaning that indeed we'll be able to reach our target. To understand the challenges and success of maternal health in South Africa and the response of the policy of government, it is important to appreciate that South Africa is in the SADC, a region that is afflicted by ill health in the form of HIV and AIDS, TB, malaria, cholera, and other communicable diseases. In addition, we have more than our fair share of non-communicable diseases, including tobacco and alcohol-related. High maternal and child mortality rates continue to be a prominent feature in the statistics of our region. As South Africa, we believe that it's only the overall development of our countries and people that resolve the health-related problems at their source. As a region, our fundamental goal is to build health systems that are based on the twin foundation of equity and justice. This is why South Africa and our president has signed the NHI Act, and our minister has recently gazetted rules which will govern the implementation of the NHI. In my responsibility as the MEC, I oversee the district, which is a pilot for NHI, which is also happening across the country. I must inform this international audience that the infrastructure we have built as part of the getting ready as world-class and comparable to the available private sector in the country and across the world. What is more encouraging is that this infrastructure is found in township and rural areas, because that's where we must intervene as far as our women, where they've been depressed before, they've been deprived of the opportunities, and that's where we're registering more maternal mortality in those particular areas. The NHI is also a critical part of the strategy to defeat maternal mortality, as it builds around the principle of placing primary health care above all forms of health care, because we believe that primary health care should be accessible for everyone, and preventative measures and programs must be put at the level of the primary health care. The NHI will allow for an aggressive strategy of preventative health care, and that is what is required to combat maternal death, as they are preventative in their nature. In pursuit of our goals, we are fully aware that there will be no easy victories, and that there will be many obstacles in our path. However, we remain committed to our vision and its practical implementation, because for us, access to healthcare is above all a basic human right. And it was articulated by the founding father of South African democracy, Comrade Nelson Mandela, when he said, I open quote, health cannot be a question of income. It is fundamental human rights, close quotes. This philosophical outlook finds expression in the section 27 of the South African Constitution, which clearly indicates that everyone has a right to access healthcare, and no one may be denied access to medical health care. This is what gives effect to the legislation that provides for free primary health care in South Africa. I must indicate that in the midst of all the challenges that we're facing, but in South Africa, primary health care is free for everyone, because we believe that we can't talk about preventative measures, we can't talk about people accessing health when you must put a price tag in terms of them accessing that. So in South Africa, we can confirm that all our primary health care is really accessible because it is free for everyone. In spite of these words from our founding father, South Africa has made significant improvements in reducing maternal, neonatal, and child mortality rates and addressing teenage pregnancies. This success, we are registering as related to maternal health, can be attributed to our strategy, which can be summarized into 5 pillar strategies. The first one being that we must meet the need of contraception to avoid unwanted and unplanned pregnancies, because this is very important. In South Africa, more than 50% of women use contraceptives or services of our family planning units, which are provided in both public and private sector, and also they are at the primary health care level, meaning that it is accessible for everyone. The government has also established youth zones which educate young people about access to contraceptives and family planning to avoid teenage pregnancy. Why youth zone? We are saying that previously our children could not go to the clinic, because when you go there you find your mother who wants to be a mother than a healthcare worker. So this youth zone, we put dedicated nurses that are trained to be able to interact, and over and above that, we allow children in school uniform that they don't have to queue in the same queue, so that they can be able to be assisted, so that they don't have to wait long up until your mother comes and finds you while you are waiting. So we make it easy for them to say, this is your daughter, this is your nurse, user-friendly, understand it, because the reality is that the teenage pregnancy is increasing. So we can't be so ignorant and want to think that these teenage pregnant are not engaging in those sexual activities at an early age. So this on its own, it contributes toward the maternal mortality, because they're not ready, they're still very young to be carrying children. Health education and promotion, this is the second one. At community level, we encourage women to attend antenatal clinics and give birth in a healthy facility in the care of a skilled attendant. This program of health education involves visiting schools through the school health program and educating pregnant women in the comfort of their homes about complications and may arise during pregnancy. Community health workers, I'm happy you mentioned them, and I'm happy in terms of your program that this is what we are going to roll out in the whole country, meaning that we are going to benefit out of that. Also, community health conduct maternal health care education as they perform their daily duties. Community health care workers
are on a different villages, if I can call that. They do door-to-door, screen, and do all these other things. And I can say that in terms of COVID-19, they did a very good job for us, because when everyone was in their homes afraid to go out, these are the people that we believe that as South Africa, we can train them and utilize whatever diseases that are there, and they can adapt easily. So hence, they will form part of making sure they assist us here. We've also partnered with traditional healers and leaders to educate our maternal health. The reality is that most of the people go to traditional healers, whether you like it or not. Hence, as a country, we work with them, we train them, educate them. This is what you can do, this you can't do. Because if you want to just criticize them, people will continue to go there, and that's where maternal deaths are. Because they give them medication, believing that the old way of doing things is what they must assist them. So when you train them, you work with them, they become part of the system of the Department of Health. That's where we are able to get positive results in terms of our outcomes. Maternal care should be respectful and dignified. The third point, we have built state-of-the-art clinic, as I've said previously, where women can access maternal health care in a dignified manner. We are also making sure that not all, previously most people believe that they can only deliver at the level of a hospital. But now our 24-hour clinic accommodates and also have got all the necessary equipment to be able to deliver. And when you are undergoing your weekly monitoring, you are able to be delivered at the clinic, because we know that you are not complicated, don't have any complication. So this is what we are doing to make sure that it doesn't take long for our women in the rural areas can just go deliver, observe 6 hours, and then go home. So that on its own, it's working. Hence, the implementation of the NHI, it's moved towards that, making sure that, because we address a lot with the capacity and the GP contracted that will be visiting our facilities at the level of a clinic. We have trained our healthcare workers to administer these services without any basic and warranted judgment. Our clinicians are trained regularly. The fourth one, efficient transport and emergency medical services are needed so that we will receive timely and appropriate care. In South Africa, we have a concept of mobile clinics wherein the department goes to remote areas to interact with women who require maternal care. We have got norms and standards where 8,000 people, you can build a clinic. Where more than 10,000 people to 20,000, you can build a 24-hour clinic. Because the 24-hour clinics for emergencies, you can have all of them at once open. So we've got 250,000 where then you are having a hospital. So where this population is less than 8,000, mainly in your rural farm areas, that's where the concept of a mobile clinic. A mobile clinic is a clinic, just that it moves. I always tell people, don't undermine a mobile clinic. It's a moving clinic, because all the services that you get in a clinic, we'll get it in a mobile clinic. So we are able to go to those areas, farm areas, and be able to provide those services. They are able to go there because it can go once, twice a month, or as and when it's needed, because the population is not as huge as the 8,000 in terms of the norms and standards that is expected for a clinic and all these other different types of clinics and hospitals. So we've also improved our system of referral from one level of care to the other, depending on the type, where you've got your district, you've got your regional hospital, you've got your tertiary hospital, and your academic. So all these are for us to make sure that when women present themselves earlier, we are able to detect that this one must go to this level of care and when they are supposed to go and deliver. The fifth, with the last one, response health care system that consider population and disease trend. We have integrated HIV and TB services, and we encourage women to require maternal health to screen for those diseases and others. The South African experience also teaches us that above the general barriers of global South, there are other barriers which a country-specific require tailor-made solution by policymakers. In this case, South Africa includes the following: socio-economic barriers. Poverty is the key determinant in maternal health. Furthermore, in 29 district health barometer, noted that women lower than socioeconomic groups are likely to be experienced. The issue of gender-based violence is a reality that is facing our people, and I believe that all of us, we should make sure that we work with our women, those that are raped, children, teenagers that are raped, and make sure that they are able to deal with the effect of HIV and AIDS and all that. If they don't want to get to give birth to a child after a rape. So these are also the rights that the women of our country must be given for that. And also cultural social barrier, of course, this is something that also we are looking at. So a call for action that we are saying, leaving no one behind. We are saying that we cannot achieve universal basic health care without addressing the root cause of health inequalities. Women and girls, particularly in vulnerable communities, must be at the center of our policies and intervention. And let us commit to a future where every woman, regardless of income, location, or background, has access to dignified, high-quality maternal health care. And let us unite in ensuring that all women are not left behind. Thank you very much.
Thank you, Honourable Manzini. I think what you've spoken about, both the challenges and the potential solutions to these kinds of challenges in South Africa, is so crucial. In particular, the sorts of cycles that you're talking about, not just looking at a woman giving birth, but really understanding the full cycle of maternal health care. Now to move over to Dr. Zek, our question is that, or is contextualized rather, by saying that the UNFPA has long championed localized approaches to achieving global SRHR goals. However, in many regions, access to these essential services remain hindered by social and economic barriers, as well as funding gaps that are being exacerbated by the current global cuts to aid funding. Given these challenges, how can the UN system work collaboratively with governments and community-led organizations to develop scalable and sustainable solutions to ensure that no one is left behind? Thank you.
Thank you. Thank you, Excellencies, distinguished guests, colleagues and friends. It's really great. Thank you so much for the government of South Africa for organizing this event. A very proud supporter of the government of South Africa. We have country office, regional offices supporting, and that comes to your question. This support has several facets, but there's obviously a magic formula that you have brought up. I think all the ingredients you were listing are really key. I want to point out one of them, and this is the human resources aspect. Midwives and nurses are crucial. We are missing 900,000 midwives globally, and we have to educate them and bring them to no one is left behind, as you were saying. We have to bring those human resources there, and we are still not there yet. So as UNFPA with partners, we want to support that more. But also when women arrive at healthcare facilities, that are not stigmatized. I've personally seen sometimes young girls who are pregnant come to the nursing station or the midwife, but the midwife is the neighbor of the mother. Mm-hmm. And then the whole rumor starts, have you heard she's pregnant, and so on. So no, quality and non-stigma, and that's very important, especially for young people, because young people are the future of tomorrow. And then the social norms, and this is probably a very important one that we forget sometimes, especially for those of us who are in public health. That's child marriage, for instance. If a girl is married very early, she will go into sexual relationship and be pregnant and probably die from a pregnancy or a childbirth. And the same is gender-based violence and rape and what you mentioned. So I think we have to also look at the social norms. Traditional leaders, but also religious leaders are very important to keep in mind when we talk about this. So the health sector is very important, but there's so many other components around that. And then to your question, I think we need to come together closer as partners, and we try this with our government partners, but also private sector. And I think South Africa has done very well, and this UNFPA wants to support that more, that there is more private sector engagement, because there is that can really support in terms of innovation. There are, for instance, midwifery apps that we are developing and using, where midwives can be educated on a daily basis on latest updates on treatment and so on. So innovation and private sector is very important. But then I want to allude also to something that we have recently developed for governments and with governments that you might want to have a look. It's Start With Her. It's our strategy on maternal and newborn health that we have developed. It was launched just a couple of weeks ago. Go on the website and have a look if you want to get some tips or hints. And I think a lot of what you were saying, what South Africa is doing, is already incorporated there. But there's so many other countries that can learn from you. And this is what we try to do with this publication, that we want to bring maternal health even more to the stage. I think there's so many issues that globally we are facing, conflicts, but also climate change and so on, that we have to make sure that we link the maternal health and keep it a top priority, but link it also to those issues. So this is one of the attempts that we try. And then finally, I think what's important to say is probably that we have to look at the most marginalized. Mothers still die out there, and they die very often in those areas where we have minorities, we have marginalized groups, and that could be a stigmatized group in whatever form, but you always have those women, and they are unheard. They're also uncounted. So in that sense, we have to start counting them and look at our data, and then also make sure, and that speaks to the financial situation you were mentioning, that we leverage funding, national funding, that we advocate for maternal health and make sure that politicians understand this is a major problem and they need to invest more. And I think, again, South Africa is really a great example, investing in maternal health and newborn health. Thank you.
Thank you. Thank you, Dr. Zek. Fascinating. And we really would encourage everyone to look at the new strategy set out by the UNFPA. It's truly a fascinating resource and document. Bello? We've heard about the policy frameworks, the global strategies for achieving universal maternal health care. One-to-One Africa has been implementing these goals at the grassroots level, working directly with last-mile communities for years now. From your experience and the experience of the organization, what are the key lessons that larger institutions, for example, governments, international agencies, donors, etc., can learn from community-led models like the Mentor Mother program to ensure that healthcare interventions are not only effective, but are also rooted in local realities?
Thank you, Gabby. It's wonderful being here. Honorable guests, friends and colleagues, thank you for having us. Please excuse my voice, I'm fighting a flu. I think in response to your question, Gabby, I think for me the first lesson would be what's in our title, leaving no one behind. Oftentimes when we speak of strategies and policies, we don't always consider those last mile, the ones that are hardest to reach. The UN SDG 3 talks about good health and well-being and explicitly states that universal health care coverage must include rural and underserved communities. That's exactly who we serve as One-to-One. We go where no one else is willing or even able to go. To a point where when we talk about even 95, 95, 95, the question is, where is that 5%? And we go where that missing 5% is. At One-to-One, we prioritize those hardest to reach areas, the ones who are facing the greatest barriers to accessing healthcare. In South Africa, MEC also alluded to this, we have a policy that says that there must be a health facility within 5 kilometers of every citizen of the country. Now, while that is true, we still face challenges even as a country, even though we've got that policy, because sometimes 5 kilometers on a tar road is very different from 5 kilometers on a rural road. We operate in areas where even the greatest and the fanciest 4x4s cannot go. So I think that's the first lesson, to really say, in whatever we are doing, the policies that are being made, let us really think about how do we access those last mile communities to make sure that when we're talking about universal access, we really are reaching everyone. The second lesson, I would say, would be around the power of collaboration. Achieving universal maternal health care is a collective responsibility that requires government, civil society, and multilateral agencies and communities to work together. The resolution on maternal and newborn child health, it emphasizes this approach that must be integrated, multi-sectoral to improve maternal and child health outcomes. An important part of that is equality in the partnerships of these collaborations. Oftentimes the civil society, we're seen as the lowest partner, and yet we are the ones on the ground, we are the ones that truly understand what is happening. So when we're talking about collaboration, there needs to be an equality in the partnership where there is space to engage from the grassroots up, and not just have policies that are created without true, meaningful consultation with civil society partners and other key partners who are on the ground, accessing, living with, and servicing and supporting these communities. Another aspect of the collaboration means that we are learning from and adapting from successful models across the different regions. The Maputo Plan of Action for SRHR urges governments to work with community-based partners to improve access to maternal and newborn health services. An example of this is that our mental mother model that we've been developing this model since 2016. We are now at a point where we are embedding this into the healthcare system in the Eastern Cape. So what this means is that we tested it. We were able to access these last mile communities, and we've done all that was required. We've worked we've worked with government, we have worked with universities and educational institutions, we've got the research. We are now at a point where we are saying, we know that this works, we've piloted, we've tested it, we've vetted it, and now we are ready to what? To embed it into the public health system. An important part of saying working in collaboration with, particularly as civil society, is that we cannot work in parallel to. If we are talking about systematic change, we have to work in collaboration and partnership with. Which brings me back to my first point. But for that to happen, there needs to be an equality of respect in these spaces of collaboration that we find ourselves in. The next lesson would be that women-led, peer-led approaches work. The Beijing Declaration and Platform for Action recognizes that women-led initiatives are crucial in achieving gender equality and improving maternal health outcomes. Our mental mother model is a testament to this because it is healthcare that is delivered by women for women. The women delivering this work are from the very communities that we are seeking. They are peers, they themselves are mothers. One of the lenses that we use at one-to-one in terms of determining the areas we need to operate in is we look at not only the hardest to reach, but those that have the highest health burdens, and in this instance, HIV. As a result, over 90% of our actual staff themselves are women, are mothers, and are living with HIV. So when they walk into a house and they do door-to-door service, immediately a person will see another peer who looks like them, who sounds like them, who understands the challenges of living in those communities, from the nuance to the stigma and anything else that is involved. And this is critical then to then our clients being able to say, I hear, I listen, and therefore I will take corrective steps from the women and the mental mothers who are serving them. So our peer model are effective because they are rooted in trust and they are based on lived experiences. And so they follow the medical care and the medical advice. They seek care and adhere to treatment when it is delivered by our mental mothers who look and sound like them. SDG 5 calls for the empowerment of all women and girls, a goal we realize every day in our work through the training and the employment that we give. The women that we recruit them locally, we recruit via the traditional system that exists there. So we will go to the traditional leaders, talk of our work, and then do the recruitment via them. And why this is important is that then it even elevates the status of the women that we are working with. These are typically women who would not have a job. The areas in which we work, we're looking at over 90% unemployment. So they would not have any other employment were they not mental mothers. But when they become mental mothers, so not only do they improve their social standing in the community, they now have an income. And that in itself speaks to a lot of self-realization that happens among the women who are our mental mothers, even before we look at the impact on the clients that we serve. The last lesson is universality of a model. We have developed a model that is anchored in this universality, ensuring that no matter where a woman lives, she can access the healthcare that she needs through the mental mother model. This is a commitment outlined in the campaign for accelerated reduction of maternal mortality in Africa, which calls for community-led solutions to be integrated into national policies. Our mentor mother model is highly adaptable, making it scalable across different healthcare systems and translatable into multiple cultural and geographic contexts. It is designed to work in rural, urban, peri-rural, and even humanitarian settings. Oh. Lastly, I'm sorry, I did say lastly before. Another lesson is that any model that governments and agencies look at, they must be holistic. There has to be an intersectoral approach to healthcare. Maternal health is not just about safe childbirth. It is about a woman's overall health and well-being before, during, and after pregnancy. The World Health Organization's resolution on maternal, newborn, and child health advocates for comprehensive approaches that include nutrition, mental health, and early childhood development. Our work also aligns with the Maputo Plan of Action, which stresses the integration of sexual reproductive health services within broader healthcare systems. And we do this by ensuring that the maternal health is not isolated from HIV care, nutrition, family planning, and early childhood development. An example of this in our work is that we provide these integrated services. We've also got a mobile clinic and are about to launch our second mobile clinic. And interestingly, this, as an organization, we didn't have any real plans and ambitions of having a mobile clinic. But it was our mentor mothers who were the ones who said, there are areas we cannot access on foot. Please, can we have a mobile clinic? And so in response to our team flagging the need, we actually purchased a truck. It is a fully fledged truck that we have converted into a clinic with 2 private consultation rooms. So people will have dignity in terms of the service that they care. It is soundproofed. And we make sure that any service, to your point, MEC, earlier, that you would access normally at a health facility, you are able to access on this mobile clinic. It goes where even the 4x4s cannot go. And going back to my initial point about collaboration, we've worked closely with the Department of Health in the Eastern Cape on this mobile clinic. We've effectively partnered with them. Where they give us medication, we provide everything else. And we're actually working on a pilot at the moment where we have said people should be able to test for HIV, and if they test positive, be initiated onto their ARVs and collect their ARVs from our mobile clinic. It has worked so far, but this is an example of collaboration. And this is what we need right now when we are talking about budget cuts and the power of leveraging what's already there. It really is about collaboration, collaboration, collaboration. I will leave the final comments to the closing comments because I really am interested in making sure that there's enough time to engage. But thank you very much.
Bello, thank you. We are going to move to a Q&A session now, but first we're honoured to be joined today by the Honourable MEC for Social Development in the Eastern Cape, Bukiwe Fanta, and so we welcome you to provide us with some remarks.
Thank you, moderator. Our panelists, distinguished guests, and partners, I greet you all this afternoon. It is great pride and deep sense of responsibility that I stand before you today to speak on the critical importance of improving maternal and child health outcomes, particularly in our rural communities. It is indeed true that healthcare alone is not enough to ensure positive maternal and healthcare outcomes. We must address the broader social determinants: poverty, malnutrition, early childhood development, and gender inequality that intersect to shape the health and well-being of our women and children. The Eastern Cape Department of Social Development is committed in playing an integral role in tackling these challenges, working in partnership with the Department of Health and other key stakeholders. Our collective efforts are guided by the implementation of the Integrated Mother and Child Development and Support Program, which is designed to empower women with children under the age of 5. who have diagnosed with malnutrition. Through this strategy, we aim to address the root causes of malnutrition, providing holistic support that nurtures not just physical health, but economic and social empowerment as well. Hence, the department offers income generation training, work opportunities, food preparation workshops, emergency relief packages, as well as micronutrition supplementation to mothers with children who are malnourished. Additionally, social development is coordinating an integrated community registration outreach program that we call ICRO, an initiative that has been assigned to us by the South African Human Rights Commission in partnership with Home Affairs, Social Security Agency, which is SASSA, and Department of Health. This program ensures comprehensive support to women with young children. In South Africa, we've got about 8 social relief grants as a country to make sure that we don't leave anyone behind. These include services ranging from birth registration and provision of IDs to access the social grants. This integrated approach is essential because it takes into account the many layers of need that our rural women face. We understand the true empowerment requires more than just access to healthcare. It requires access to resources, education, and ability to generate income to support their families. In closing, there are immense opportunities for collaboration between government, civil society, and international partners. By working together, we can ensure that our approach to maternal health and child well-being is truly holistic, sustainable, and far-reaching. International partnership but in particular can play a pivotal role in ensuring that you have the resources and expertise necessary to make a lasting impact in our rural communities. Let us work collaboratively, not just to address the immediate needs of our communities, but to create a future where every woman and child has the opportunity to thrive. I thank you.
Thank you, Honourable MEC. Dr. Zetto talked earlier about the need to increase the number of midwives that we have working with our programs, with our governments, with our initiatives. And we're joined today by a South African midwife, Lungile, who I believe has a question for the panel or comments to make on the topic. So I welcome you to speak.
Thank you so much. Greetings, Honourable MECs and all our honourable guests on the panel. My name is Lungile, as introduced, and I'm a midwife working in South Africa's public health sector. And I'm so happy to just hear of all the efforts that have been made by, our government. Honourable Minister, you mentioned, just the strides we've done to contribute towards the VMC through our NHI development, and I'm just remembering also how the government has also contributed towards this with, the ideal clinic and hospital setup. Very helpful, I must say, as someone working in the public system, and also just the capacitating of midwives through in UNFPA. That's really great. I'd love to know more about the app and just improving access from your end with reaching women. And I love the mentor mothers model, because I believe it's not only bridging access physically, financially, but also just the acceptability aspect of access, because a lot can be available, but if it's not acceptable to a lot of women, then it's not accessible. So through language and just relation, through cultural appropriateness, it's just fantastic. I really applaud that. I think also just what came to mind as I was thinking about the theme of leaving no one behind is also the role that traditional midwives or birth attendants actually play in this broader scheme of leaving no one behind. And I think it's just something to also remember as we think about universal healthcare coverage and just leaving no one behind, because they play an immense role. So like we're doing with traditional leaders, traditional healers rather, we should also, I think, consider bringing them along and capacitating them as well. And lastly, I think I just want to mention the importance of HRH for maternal and child health. I think it's really important to take that into consideration. And as a midwife, I'm just seeing some, some things that we also need to pay attention to in our future as South Africans, which is the fact that, it's known that midwifery and nursing in general is an aging profession. So we really need to put hands together in terms of just recruiting, retaining more midwives and nurses within the public healthcare system. So that's all on my end, and I really look forward to more engagements, and thinking about, I have a lot to say, but I think I'll cap it there. Thank you.
Thank you very much. I think we'll take maybe 2 more questions from the audience or comments from the audience and then allow our panelists to respond. I know I had a comment over here and then a comment over here, and we'll come to you in the next round.
Hello. Good afternoon. First of all, let me just give you an intro of myself before my question. Okay. I do have a disability. I do have cerebral palsy. And I'm a lawyer, so please pardon me. You can't hear me very well.
Okay.
Now, per all your submission, okay, you are lacking what I call the issue of inclusivity. Now, I'm a mom, and I'm also going to be a soon-to-be mom again. Okay, now, the ordeal I had to go through for my first daughter was horrible. I had in Ghana, the issue with the healthcare system in Africa, in most part of Africa, be it urban, be it rural, is a fact that, when you have a disability, already the traditional system is against you. They might want to happen to you. Now, as a midwife, going to school, going to all the training, they are so prejudiced against you. Now, I go to the hospital, I was in labor, and I was like, you know what? I want to induce my labor. You know what the midwife said? He said, call your mom. Or call your husband. I feel I'm not of sound. See, throughout this whole CSW69, it really like the issue of inclusivity. Because what we're talking about here is like able women. Everything about able women. But I can do it by fact, if we're not intentional, if we're active, 5 years from now, we'll be here on the same table here discussing this issue. So, as a mom and of work, as a soon-to-be mom of 2, I will admonish, as a lawyer, as a human activist, as a disability activist, please, don't just look at it on the oversight. Be intentional. Don't just look at the traditional healing, because they are the girls. The traditional leader. I mean, come on. Our culture, our custom, again, people with disabilities. So now, the issue of mortality rate, maternal mortality rate, I'm talking about hair. I don't believe the whole number. Because there's a woman somewhere in the village who is blind, who has HIV/AIDS, and who has other forms of disability, and had to die because she was being stigmatized by her village, by the community. So please, a very heartfelt plea that don't just look at it.
Yeah.
I'm tired. I've been there for 2 weeks, and then I've been here in 2 minutes. Gender equality, everything be burdened on an able woman. Forgetting that I am first a woman before a person was able to be. So you don't fight for me now. I don't know who. Thank you.
Thank you very much for your contribution. I'll invite one more question and then we'll allow the panelists to respond and then we'll go to another round of questions and interventions afterwards. Please.
Good afternoon to esteemed panelists and my fellow colleagues present here. I'm Neha. I'm the Director of Fellowships and Training at Incision Global. We're a network of medical students, residents, and public health advocates that work together to push the agenda of global surgery into universal healthcare. With over 800 women dying daily from preventable pregnancy-related causes, and C-sections being essential for 5 to 15% of the births, access to surgical care and trained providers remain a crucial and often missing link in maternal health. I admire how One-to-One Africa is strengthening preventative healthcare, building infrastructure, and also reinforcing primary healthcare, aligning with the principle that healthcare is a human right. But I'd like to add the words of my inspiration, Dr. Paul Former. He says, surgery is human right too. So what are we doing to ensure that surgery is also part of the universal healthcare? And what are you doing to, for primary healthcare is exactly what Incision aims to do for surgical care. So how can we collaborate and incorporate surgical care into universal healthcare and make this a reality for everybody and actually leave no one behind in all aspects? Yeah, thank you so much.
Thank you. So I'll allow the panelists to respond, perhaps in the order that you spoke originally, and just a reminder of our questions and interventions around midwives and birth attendants, around the questions of inclusivity, specifically around disability, and about the questions of access to surgical care as it relates to maternal health.
Thank you very much for the input that I made and the question that has been posed to us. Indeed, I want to agree with you that in terms of the midwives in our country, South Africa, in fact, in terms of when you look at our nurses in our country, most of them are going to be retiring and some of them are leaving the country, meaning that we need to train more of our nurses, just professional nurses, and of course the midwifery is something that in the country, the National Department of Higher Learning is working with provinces in terms of the colleges that we are having, and we are looking at increasing the number of institutions that will be providing training in making sure that indeed we have more specialized midwifery. That is very important because that will reduce the number of people that will be going to our hospitals, because if we have got more midwifery at the level where I've indicated that in South Africa we have what we call CHC, which are your primary health care that are 24 hours. And in the main, what you do is not just to extend hours, but you must be having a facility that meet the requirements so that a woman from the villages don't have to go to hospital. And that on its own, what is the challenge also is the number of midwives that we are having. So indeed you're correct. That's what we are looking at. That's what we are increasing the number of facilities that will be training in terms of the midwifery that we must be having. In terms of the ideal clinic, you are correct that in terms of the preparation for the NHI, we are looking at making sure that all our clinics are ideal. I can report that in our NHC, which is our National Health Council, we were doing well in terms of primary health care. In terms of almost the provinces, in terms of ideal, we are doing very well. And that on its own, it means that when people are saying, are you ready for the implementation of the NHI, we are ready because in terms of our clinics meeting that requirements, and also in terms of making sure that the OHSC standard also accredit our facilities in terms of that. The ideal clinic is that the infrastructure in terms of your health facilities, whether it's your cleanliness, whether it is also safe for our people, and also the staff that you must be in those facilities. So we can say that if you are correct, and I can also indicate that we are moving towards the right direction as far as that. And I'm happy that we are here and we are also agreeing that that's what we are doing in terms of also the electronic system. We have started in terms of making sure that we've got one system in our country, be it private or public, that on its own, it means that it will make our treatment to be fast, our treatment to be efficient, so that you don't have to be going around and opening file. And what is good about the system is that it also deals with your looking at your screening. So every patient that go to the clinic, in terms of the system, it will be looking at your system. We are even looking at being reminded to say now you're 3 months, you're supposed to have checked your breast cancer, you're supposed to check your diabetes, your hypertension, your HIV, and you last tested in the last 3 months or 6 months. So this electronic system is something that we are very proud because we have started it, and we are going to making sure that we put it in the whole country and also move it towards our hospitals, because now it's the level of the primary health care. So I agree with you that indeed the issue of ideal clinic is very important, and that's what we are moving towards, making sure that, as the minister have indicated, that is towards making sure that the national health insurance is the solution for the people of our country, because as much as people are criticizing it, but it's something that we will be able to make sure that every South African does have access to health, proper quality healthcare system in the country. The second one, I really agree with you. Indeed, in fact, all of us, we didn't say anything about people with disability. We must apologize. We must apologize that we did not touch that. And but that does not mean that we're not doing anything. We are doing everything, starting from the access that we are referring to. We are making sure that the facilities that we are referring to are easily accessible for everyone. And indeed, we are making sure that in South Africa, there's a percentage that you have put in place to make sure that they are also part. When there's this slogan that there's no us without nothing about us without us. So yes, we are indeed making sure that they are included, they are part of the system, the implementation. So indeed, it's something that we must all of us correct, so that when we speak, it should be in our. It should be easily in our tongue without being in it as a topic. Because once it becomes a topic, that's where we are losing it. But it should be something that we know that in every topic that you talk about, you can't exclude. So once our minds have been channeled to say, because it's not part of what we must talk about. No, we should include it. And hence I'm saying that we really apologize for that. But if we had an opportunity, indeed, we will be saying that this is what we are doing. But there's a lot that we are doing. Indeed, our traditional authorities in South Africa, to some extent, they have transformed. Because there's what we call the House of Traditional Leaders, where they are part of the executive will go to the House of Traditional Leaders and report on any matter. And in whatever that they're doing, like in the topic of health, they open their offices, we bring their services to their offices, so that we extend access through their offices, so that each and every member, because the reality is that most of the people in the country will come from or Africa, or it's rural. So it means that we are all we are their subject. So everything that we are doing, we include them, and they are part of that. And I can assure you that in South Africa we have transformed. You can't find where they are being discriminated. In fact, they are fighting that they should also be part. And I believe that indeed you're correct. There's a lot that we can talk about as far as that is concerned. The last one is that the issue of making sure that the surgery, as far as the maternal mortality is concerned, you're correct. What does that mean? It means that we must have more of our doctors being trained, have specialists that will also assist us in that regard, have more pediatricians, have more gynecologists that must be in our facilities. As much as we are posing a question, it tells us that the gynecologists that we are putting them at the level of the hospital and district and in the main regional specialized hospital, it means we must train more. That will be at the level where, because when we are saying that primary health care is where the services must be, it means that we must have more of them at that level. So it's something that we must be taking out of this. I'm one taking out of this to say, as much as we are talking about GP contracting being part of the primary health care, we must look at that also. It might not be each and every clinic, but in the form of a cluster, we must have more gynecologists that will be assisting and intervening so that we can also deal with the mortality of maternal mortality. So we really appreciate all the input that has been made, and we believe that with your input and what we are currently doing, we can improve in making sure that all of us, when we come back, we are saying that we've reduced and we are moving towards reaching our target, all of us as a global index. Thank you very much.
I'm going to intervene to ask our other two panelists to be brief so that we can get to further questions. With all respect due to the Honourable MEC for your very thorough and profound response to those questions.
Yeah.
Please.
Just quickly, so thank you. Very impressive speech, I would almost say. Really great, thank you. I think it's difficult to change a community because it's a long process to understand impairment and disability. But what we can change is when the person arrives at the health care center to be received with dignity, and this is where we can start educating midwives, have ethical training for every staff, and I think that's part of the curriculum already in South Africa, but it has to be re-emphasized. In some communities, I think disabled persons are sometimes even hidden. They're not even seen. That's even worse, right? So we have to keep fighting for it, and thank you, and congratulations that you will have a second baby. It's really and then secondly, on cesarean section, there's some interesting studies saying, if you look at big numbers, that the peak time of cesarean section is a Friday afternoon. Because everyone wants to go home, let's quickly do, finish everything quickly. That's not the right way of surgical intervention. So we have to be very careful. There are some countries in other continents where the cesarean section rate is increasing massively because of that. But there are also some beliefs in some cultures that there are certain lucky days, that women demand a cesarean section a certain day because it's a lucky day. This is not what doctors should be doing. So what we need is, I think, a good mix of midwives and doctors in collaboration who support each other in doing the right thing and provide quality and not over cesarean sectionizing. Because what will happen is then once you have a cesarean section, you have a second, and then most of them you need family planning because a third one is very dangerous. So, and then first of all, we deprive the woman to have a third child. And thirdly, if she gets older and she needs some ovary removal or something, it can become very complicated because 2 or 3 cesarean sections can make a lot of adhesions in the abdomen. So 1 cesarean section is fine, maybe 2, but not more. So that balance is very important.
Thank you. I'll just jump straight to the question on disability. Noted, let me actually not ignore it. That's well noted, and in fact we are looking, there's training that's already on the card that we are discussing for our mentor mothers, which is the equivalent of community health workers, to be trained as well, even if that's not going to be their primary focus, just so that they have the skill. Because what tends to happen is people will go into labor at 11 o'clock at night. Clinics there are not open, there's no access to hospitals, and sometimes they call our mentor mothers to say, come and help. And so even though the community health worker is the lowest cadre of within the health system, but it is important that they still have that skill to be able to assist, because sometimes they are the only ones available to assist in communities. And then if I can come to this question on disability, thank you for bringing that up, and I echo the apology that we weren't explicit in saying it, but it's certainly a part of what we do and how we do what we do. Our mentor mother model, for example, every single household, so we're currently covering over 39 villages, every single household in those villages we have been in. So there is no house that goes unseen, which means that everyone that we see in those households, we do then take care of. Our footprint into every home is maternal and child health. But by virtue of us being in that home, when we see a problem, we're not going to walk out and say, well, it's not our problem. No. A part of what we do, we very much understand that because of where we operate, sometimes we are the only access to health that people have. So there is that recognition. And in fact, we've started to be quite cognizant of that in our programming. We've got an ECD program that we have, for example, where we've developed a component. We call it Baby Ubuntu Firstly, for parents themselves who are living with a disability, or for parents who have a child that has a disability, so that the parents are able to even identify if their child has a developmental disability in any way, shape, or form, or even a physical disability. Because that's another problem that tends to happen, that children are reported late because parents don't know. And yes, in our cultures, we'll call them names, we'll say you've been bewitched, you've been this and that, whereas it's really just a developmental issue, but parents don't know how to address that. So in our programming, we've actually started to introduce that as well, to empower the caregivers themselves to be able to start identifying any issues of disabilities in their children from the get-go. And then lastly, the comment around surgery being a universal, universal access to surgery. Me personally, I love it, right? But I'm speaking as someone from grassroots level, but we're also dealing, our clients typically don't access hospitals because of where they operate, because it is so last mile. But I think there's a lot to be said about collaboration, and Dr. Zek and both the MEC, I think, alluded to what can be done in terms of collaboration. I mean, in South Africa, I'm just thinking out loud here, in South Africa we have that two-year in-service training after medical school. And there's so many possibilities for what can be done with that. And I think it's really about saying, what are the challenges, who are the partners who have a vested interest, and what can we do about it? Because we will tell you where the people are and what the needs are. Whereas the Department of Health will tell you something different, and UNFPA will tell you something different, and you will tell us something different. But when we are able to come together and say, all right, as a collective, what can we do? And again, I emphasize equality of reception of what we are talking about. I think is key.
Thank you very much. So I saw your hand first, number 2, number 3, number 4, and then we'll try to do one more round afterwards if we have time. We've got this. Please.
Thank you so much. My name is Christine. I'm a practicing attorney in South Africa, immigration attorney, and I'm also a UN ambassador for gender priority strategies in Africa. So sitting in this session has been quite enlightening to see what's happening in South Africa, and I'm very happy with what I heard, but it also raised a few questions in my mind. So I think I've got 1 or 2 questions. First of all, to the MEC, you spoke about Section 27 of the Constitution, which grants access to healthcare for everyone. And I believe everyone incorporates migrants as well, anyone within the borders of South Africa. But I'm sitting here today telling you that I have clients who actually died waiting for their visas in South Africa, being denied access to healthcare. I know the visa system is out of your portfolio perhaps, but the healthcare is within your portfolio. How then are you tackling this? I know you're in Mpumalanga, but sorry.
Oh. Sorry. That's heartbreaking.
Take your time.
Yeah, so I think my question is just really, there are migrants who are being denied access to healthcare in South Africa just because they are migrants in South Africa. So how is that being tackled by the government? And then secondly, there was, I appreciate the work that One-to-One is doing with the child and infant-child mortality and all of that. But I just wanted to ask in terms of post-childbirth, we need to have those constant checkups, like women get into menopause and they're unaware that they're now in menopause and they're suffering unaware of what's happening to them. Do you have in your program, is there anything that you're also doing to help women post that? Because early childbirth will accelerate some of the biological things that happen to you. So, yeah, getting into early menopause, having to have pap smears regularly, cervical cancer jabs, and all of that. Is there something that you are also doing to help women post the childbirth? And then, and the mammograms and all of that. So there's a whole lot of post-childbirth health issues that need to be addressed. So I just wanted to understand that. and I appreciate what you're doing. It's in the Eastern Cape, correct me if I'm wrong, but is there a chance of going beyond the Eastern Cape? I'm a mother of 3 girls. Dr. Zek said that once you have 1 or 2 cesarean sections, you can't have a 3rd one. I've had 3 cesarean sections, and I nearly died at the 2nd one. Why? Because I went into labor when I was in Limpopo. I was doing work in Toyando, and then I went into labor. I was taken to a local hospital, not a clinic, a local hospital in Limpopo. And I was told, no, you're in labor. You just need to chill, you know. And because I had a previous C-section, that previous C-section ruptured. Once I was told to just stay in labor like that until I was taken to Polokwane. I'm fortunate that I had family to take me to Polokwane and give birth in Polokwane, but what happened to those other women who don't have that privilege? So whilst I really appreciate what you're doing in the Eastern Cape, it would be really beneficial to extend to those other provinces where they're facing similar challenges. So yeah, that is it from my side. Thank you very much.
Thank you very much. Please.
Thank you very much, moderator. I'm Rose Molokwane from South Africa. I'm the leader of the community organization called FEDA, dealing with women issues from housing, land, and poverty alleviation. I'm really happy to listen to what the MEC is saying, Dr. Zek and Mama. So inspiring and wanting to understand further. You know, when I was listening to the 2 mamas here and hearing about the mentor-mother model and comparing to our nurses and midwives, it's a very total different approach. I can see that the mentor-mother, they are there at the people, and they've got the passion. I'm saying this out of the experience of what is happening in our clinics and our hospitals. When you go there, you find that the nurses are sitting in that reception, talking, taking discussion, not caring about the sick people. And then you ask yourself, they've got the epaulets, beautiful uniform, but the hands and the mind are not with the people on the ground. People are dying because they don't get proper care from our people that we are trusting to be supporting us. And I'm wondering, and we are now having the NHI, it's a very good approach of our government to give us free health care. My question is, are these people going to use it to save the lives of the people? Because in my hospital where I stay, I always call our public hospital Lindukufa, wait to die, because there's no care. And the hospital is so beautiful with all the equipments inside, and the human resource that we are talking about. How can we address the human resource of our public hospitals? You compare the private hospital and our public hospital. Again, they are totally different. People with a lot of money that can afford to pay private hospital, they get good care and they survive. But with our public hospital, beautiful buildings, but inside you can have shame when you look at what our nurses are saying to our people who are sick. What I like to also understand, during the COVID-19, I remember there was this issue that came out of homemade remedies to address COVID-19. I just wanted to understand, how does our Department of Health take the homemade remedies that helps to cure some of the illnesses in our communities? And then finally, we are talking about the mother. I like that one. Mental mother. I like it so much, and I'm going to preach it when I go back home. I also want to see it happening properly in our informal settlements, because even if we talk about rural women, but we also have more challenges at the urban areas, especially at the informal settlements, where there are no clinics, there are no hospitals. You have to drive a long distance to go to the hospital or to the clinic. How do we address that kind of issue also to add more of mobile clinics in informal settlements? Because that's where health hazard is a lot happening. If housing is not being addressed, security of tenure is not addressed, people are just staying because they are waiting to be evicted. But now, how do we, the collaboration now again for different departments? We did hear the social development is partnering with health. What about housing? What about land? Because if people don't have adequate land, adequate housing, it won't work, because the more people are lacking housing, is the more health hazard is affecting the families, and is the more the death or the number of deaths of people are happening. I'm a community leader. I see this every day when I deal with our communities, when I organize women, when we address children issues, young children issues, youth, and everywhere. We are faced with difficulties and don't know how to address it. But if government can also come to us, we'll work better together and address these issues adequately. Thank you.
I'm very conscious of the time, so we're going to take two of the last questions quickly. I think it was your hand up. If you have further questions, we're here. We can meet outside. Let's chat further. Please take our contact details and let's continue this conversation.
I'm just going to be quick. So I'm Afua York. I'm an assistant professor at the University of Washington. I was born and raised in Ghana, so I'm sort of like here on for two countries, so to speak. I walked in when the rep for One-on-One Africa was speaking, and such a remarkable progress that your organization has made. You talked about, a model that has worked, and in my experience, I also do research in global health, but I work in cancer care, mostly in sub-Saharan Africa. When we create models, the goal is to use that model for other people to use that model as a template to implement, in their local places. I've gone to other meetings during the CSW, 69, and mostly I've been targeting the side events from other African missions. And the word that I hear that comes up a lot is, we're doing this in Africa, but then at the table, it's practically, just a few countries represented. I'm posing a question to, the panelists. Don't feel inclined to answer. But yesterday I was watching Al Jazeera, and with all the, USAID cuts, there was a question, there was a response from the person that was being interviewed, and she mentioned that, does Africa has an African position? I guess my question for the panelists here is, if we come back next year for CSW 70, because we're 5 years away from SDG, 30, are we going to have an African position on maternal health and child, care? Because everything that everyone is saying here in this meeting is exactly what is happening in Ghana, in Uganda, in Nigeria, in Cameroon. But then when we come here and we just present from one point of view, then we are back in the position where we're working in silos. And we all know in the world of public health and global health, working in silos doesn't help anybody. So let's go with the African position. Let's hear from other people. And I guess for you, One-on-One Africa, I want to know what you've done. You don't have to answer this again, but think about, how to collaborate with other people in other countries that are doing similar work, because HIV is no respecter of people, and everybody, people have it in other places. Let's figure out how to work together so that we're not working in silos.
Thank you. And our final question, and then I will ask the panelists to respond to some, many, all of the points that have been brought up. This has been such an interesting and rich cycle of questions. Thank you.
I hope I'm loud enough. And, thank you so much for your presentations to the panel and moderator. I would like to ask a question on the mental mother. and how is it inclusive to male? Because in the African society, the man holds the power and the resources, even for accessing healthcare, even for simple things like permission to go to the facility. Another question is you really have a good model. What is the plan after the CSW on sharing this globally? Because adaptability to only one side of the country will not be beneficial. How do you ensure that it's regionally adaptable to South Africa and also to the rest of Africa?
Thank you. Okay, so I'm going to do a very quick outline of top points from each question. I'm going to attempt to do it at least. And please answer to the best of your abilities and from your various perspectives. And I will also ask that you end your answers with any closing remarks you have, because I don't think we'll have a chance afterwards to have closing remarks. Some of the topics that have been covered during this round of questions included the question of Section 27 of the Constitution. When we say healthcare for all, how do we ensure that includes migrants in South Africa? Questions of post-childbirth care at 1-to-1. What are the visions for expanding outside of the Eastern Cape to the whole country or to further that beyond South African borders? Questions of how do we ensure that the NHI is implemented effectively. It's all very well to have good policy, but we also have to have equally good implementation. Questions on homemade remedies and traditional medicine, on the mobile clinic, in informal settlements, again, on expanding these sorts of models beyond just South African borders. How do we collaborate with other organizations from the continent and across the globe? And what is the role of men in the mental mother model? How do we integrate male engagement into our programs? Thank you.
Good job. Thank you very much for your inputs, and also, as I've said, that we believe that everything that is raised in this meeting is important, and for us is to make sure that how then do we, where we are criticized, and go back and make sure that we improve on that, and also where we need to clarify, we must do that. I think the issue of the immigration in South Africa, in terms of South Africa, emergency and primary health care should be provided. And I'm happy that you are even saying maybe because you are from Mpumalanga. Because when you go to Mpumalanga, where I come from, we have got undocumented patients that we are unable to trace. Hence, also in terms of the budget that we have been allocated, is far less than the people that we are seeing. Why? Because of the many undocumented people that are not from South Africa. For something that to me is painful as an MEC in Mpumalanga, to an extent where, because now we are putting an electronic system, you have people coming from outside the country, moving around in a taxi, going to one clinic and the other, collecting medication because they are allowed, without documents. They are allowed to an extent where it becomes a problem for us, because they are collecting, because they know towards the end of the month, they are going back home, they will be going to clinics and collecting. So I agree with you when you are saying that maybe where you come from is something that we need to check in terms of where are they not allowed access to healthcare in the province. Also, because we meet in our NHC, also our counterpart, like the one from Gauteng, will be saying that majority of people in Gauteng, they are not from South Africa. And hence the numbers that we are seeing as a country is more than the population that we are having. If we want to put the public and the primary one, public and private one. So it basically will also depend on where you are and the experience that you had. But my experience as the Ministry of Health is that we are giving more services to undocumented, not only for health, also for education. In the beginning of the year, we'll have more people enrolling up until grade 12. But when now we must have an ID in grade 12, that's why you are able to realize that you've got more undocumented. Why? Because there's no discrimination in South Africa as far as for you to get an access to health or even education, you must produce an ID. It will only catch up with you towards the end. So where I'm coming from, I can't say that is not true, because that's what we have experienced. But I've got another experience as the MEC of Health in Mpumalanga, in terms of more people that are servicing, in terms of immigration. So I just want to check where from we can do it outside, as far as where and where. Even the MEC of Limpopo was even saying, now when she has got a program that is called Rural Province Matters, in terms of expensive gestation, People will be transporting people from other countries to come and queue and become part of the program. That is meant for South Africa. And now we are complaining. So we are complaining because we are servicing more people that are not from South Africa. So I'm just saying that it depends on where you are and the experience that you had as far as immigration is concerned. But in terms of access, it should be on primary health care and also emergency. That's where we must be providing people who are not South African. But major services that we can't afford for our own people, it becomes a problem to find a balance, but we are doing it even though it becomes expensive for us.
1 more minute.
Oh. Don't forget I'm a politician, so I'm unlike this too. And there's a lot of things that have been said. So I'm just saying that what we have said, also there's emergency services that we provide, that we extend. I always say a clinic might open for 8 hours, but the clinic is open for 24 hours, or healthcare services, because when the clinic is closed, and also the hospital that we are referring to, we are extending it using the EMS, because our EMS are 24 hours where they can take you from your home to where the hospital is. It might have its challenges, but it's there. I know there are provinces now where they have moved towards 1 ambulance to 1 ward. So that's how far we have moved as a province in terms of making sure that there's access. Still needs to be done, more support we need, but we believe that if we can work together, civil society, as government, we can do more in terms of making sure that our people are provided the quality healthcare service that they deserve. And I believe that we're not that much bad, but we need to do more in terms of making sure that at the end, hence we are saying the NHI is the solution for the people of South Africa, because 85% of the budget of that is come from the GDP. It is going to health, but it is going to those with private medical aid. You said that you were hoping, people are saying that private hospital is better because they are paying. I always tell my people, the 85% of the population, that there's no nurse, there's no doctor that will tell you that you don't pay, because you have paid upfront. In a private hospital, before a doctor touches you and operates you, they must call, get authorization. If they don't get that authorization, you are moved from that private hospital to us, public. In the public, we don't ask you, we just give you all the services that you need. So all the services that are private, from our service, that it is paid in advance. So that one, you must wait until they remove you from that bed, because they do. I get calls that will tell me, MEC, we are removing a person from a private because there's no approval, and we will welcome you there in our public hospital, and we won't ask you anything, we'll just give you the service that you need, because the same services that are there is also there in the public service. Thank you very much.
Yeah.
Thank you, MC.
Thank you. I'll answer a few, but I'll try to do it in literally 2 minutes and do closing remarks. The easy ones to answer is, there was a comment around the men, to say how do we start engaging the men. We actually have, in fact, let me take a step back. Everything we do at one-to-one has a child at the center. Child and the woman, the mother and child, that dyad is at the center of everything that we do. Our approach is, if it's true that it takes a village to raise a child, our approach is, it takes a healthy village to raise a healthy child. So when you are looking at the village, you need to look beyond the mother and the child. As a result, we have a program called the Male Engagement Program to speak to exactly that, where you start pulling men into conversations around HIV, maternal and child health, how to look after a child care, and all of that, because we recognize that men are still the heads of households, because we operate in traditional areas. So we actually have a program speaking to that. And then in terms of our approach as one-to-one, in terms of scale, we're not trying to be a big organization. We like to test, pilot, work with partners, and then they will be the ones to scale. For example, we're embedding our program now into the Eastern Cape Department of Health, so they will scale it effectively. And that's our approach. Whether we're talking about different provinces, different countries, or different areas, or INGOs, we are about saying, let us work with you. We have a program, we have a model, it works, and our model is adaptable, and that's the best part of it. And then it's about anyone else who is interested in talking to us to then roll it out in their areas. And then just
1 minute.
1 minute. Just why the mental mother model is so important in the bigger scheme of things is that it ensures early presentation. When a person presents early, there are less complications, and therefore it is less cost. The other thing about the mental mother model is we teach people how to advocate. So people are scared to speak against a nurse or a doctor. So initially, the mentor mother will speak on their behalf, but as the mentor mother is walking the journey, the person sees how to advocate for themselves. That's the end goal, that people are able to advocate, so that when you are told to wait, you can say, no, I cannot wait. There's nothing more fascinating that I've seen in my line of work than to see a mentor mother arguing with a professional nurse. It's the stuff of dreams, where she literally said, I will not take my client back. My client has TB, has to be taken in, and the nurse refused. And she said, I am not leaving until the client is admitted, and they were. In closing comments, the mentor mother model works for 4 quick reasons. 1, it is woman-led, and it is peer-led, and it is driven by trust, engagement, and it drives long-term behavior change. Secondly, it is holistic and intersectional. It is about empowering women to empower their communities. It works across health, education, social development sectors, and ensures that mothers and children receive comprehensive health care. It is scalable, it is adaptable. And lastly, it is sustainable because we are building local capacity by training people from those communities. Our approach and our model is not just about treating systems, it is about transforming communities. Thank you.
Thank you.
And just finally, just to say, the experience that you had, I know the experience is international. You see healthcare workers with cell phones and they're not interested. I think one way to do it is to review maternal deaths together, and this is sometimes a wake-up call for some of the healthcare workers. Just to say finally, to end on a positive note, having a baby is a miracle. And who has experienced or seen it knows, and we all came that way. We all have a mother. We're all lucky enough to have survived it. So let's end on this and see it positively. Thank you.
Thank you very much.